Mary was saying just now is extremely important and impactful. I just want to let you know that. Okay, so my name is Jeff Mercani. Thanks so much for having me. I appreciate the opportunity really to give y'all a quick overview of wastewater surveillance and also speak about the launch of CDC's.
You cannot talk or listen until the host admits you to the meeting.
Yeah, basically I'm going to be giving a quick overview of wastewater surveillance and speak about the launch of CDC's National Wastewater Surveillance System for COVID-19 response. Like I said, my name is Jeff Mercani. I'm the acting lead for the National Wastewater Surveillance System at the CDC right now. So I'm going to try to share my screen and see if I can get this to work properly, and then we can move forward. Let's see, just got to figure out which screen to share. I think it's this one. Okay. Okay, so I think I might be sharing my one with notes, right? Okay, so let me switch this up because I've got some notes there that those are for me. Let's see, how do I display settings? How does that look? That's just my presentation, no notes. All
Looks
good.
great.
Let's oh, welcome to our lives right now. Okay, so I really want to start by talking about what wastewater surveillance is and why it's such a promising new tool in the public health toolbox. And by the way, if my audio goes out or something is completely wrong, someone just flail your arms. I'll try to stop, and I'll try to take. You can even hold up a piece of paper with some words on it. That's good too. I'm good. I've been through just about everything here. So if you see a toddler running through the background, that's probably just my toddler taking the mail and tearing it up. So like I said, I want to start by talking about what wastewater surveillance is and why it's such a promising new tool in the public health toolbox. So wastewater surveillance is the strategic sampling and testing of pathogens or other health targets in wastewater to better understand disease burden and spread within a community. So wastewater surveillance is not a new idea. For decades, CDC has been using it for polio surveillance. However, the COVID-19 response is the first time this type of surveillance is being implemented at scale across the US, and the first time it has been used in a response for a respiratory infection from the CDC. Wastewater surveillance is a promising new tool for the COVID-19 response because the virus is shed in the feces of up to about 80% of infected people, both who are symptomatic and asymptomatic. And since the majority of feces in America will be flushed into the sewers and arrive at a wastewater treatment facility within several hours to a day, untreated wastewater can be seen as an efficient pooled fecal sample representing community level or even in some cases sub-community level infections. Wastewater data are unique from case-based surveillance because wastewater captures these subclinical infections and it's independent of healthcare seeking behavior and testing access, which is extremely important for this. Finally, wastewater data have been shown to be a leading indicator of trends in new reported cases by anywhere from 4 days to even a few weeks. With all these benefits, it's important to note that testing wastewater cannot determine the most effective mitigation strategies for reducing transmission within a community. And as such, it is not a tool that is used in isolation, but instead used alongside other important health indicators. So as part of the public health toolbox, we envision health departments using wastewater-based surveillance data to inform response decisions. However, as I mentioned, wastewater-based surveillance data is not intended to replace traditional surveillance indicators, but instead has the potential to complement case and symptom-based surveillance data, which target only the top 3 tiers of the surveillance pyramid that you see pictured here. While wastewater data isn't perfect, its imperfections are definitely distinct from flaws of other testing-based surveillance systems, which means wastewater could potentially provide resolution to conflicting clinical-based indicator trends. It could also provide infection data for communities where testing data isn't available and potentially provide an understanding of sub-county infection variability. And finally, wastewater could provide information on viral circulation within a community during subclinical phases of the outbreak when there are no cases being reported. So despite its promises, we need to also understand what the limitations are. And there are limitations to wastewater data, what it can tell us, that are often overlooked when discussing the use of this type of surveillance. First, the surveillance limit of detection is not known. Specifically, it's unclear how many people need to be infected in a system to be reliably detected in wastewater. Thus, low incidence infection prevalence may not be captured by wastewater surveillance. Along the same lines, a single wastewater measurement cannot be used to definitively clear or lock down a community, but instead wastewater trends over time can supplement other surveillance data to help make those sorts of decisions. Additionally, about a quarter of American homes are on septic-based systems, and therefore those individuals would not be regularly captured by wastewater surveillance. This will have the biggest impact on the usefulness of wastewater in very rural or coastal communities that are primarily served by septic systems. In many facilities, wastewater may not be accessible for sampling at all. And at the system level, operations need to be considered when selecting a utility for surveillance because some systems have pretreatments installed prior to the plant intake for worker safety reasons. And these measures could significantly impact wastewater-based disease surveillance data. Also, to be useful for rapid public health action, wastewater sampling and testing may be required at a high frequency and with a fast turnaround. Finally, there's an additional limitation on the ability to sample and test itself, specifically regarding the intense competition, as you may all know, for resources, including the lab capacity, supplies, and equipment. So with all these limitations acknowledged, and based on data from a scientific evaluation earlier this year by the CDC and its academic partners, it was clear that wastewater surveillance could provide actionable information for the COVID response. So in September of this year, we launched the National Wastewater Surveillance System, or NEWS as we refer to it, and we've created lots of good puns for it as well. Um, so starting in the top left, wastewater treatment plants collect samples in this system, collect samples of incoming raw wastewater or primary sludge from communities, and these samples are then submitted to laboratories for analysis. The labs send the results to the state and local health departments where it is uploaded to the news data repository, an analysis engine housed at CDC. The analysis performed by the news analytics engine is rapidly made available to health departments through the data portal, which also allows states to view wastewater data reports from other states to coordinate and understand transmission in neighboring communities as well. So in order to implement the news system during the pandemic, we are focusing right now on these 5 areas, some of which I will provide a bit more detail in the coming slides. These areas include onboarding of early wastewater surveillance implementing states, as well as some localities that are smaller than states, providing online guidance documents to support state and local implementation, providing laboratory support for public health labs, and through building federal testing capacity in partnership with the U.S. Geological Survey and EPA, which supports urgent wastewater testing response needs outside of news partner capacity. Creation of a news data submission portal through the CDC Decipher system, and finally, evaluation of applications of wastewater surveillance at the building and facility level, which is what we call targeted use cases. The use of wastewater surveillance for building level infection screening may be one of the most impactful uses of this tool, but it's also the use that is the least characterized. So we're developing partnerships currently to better understand this application. So as I mentioned, NEWS is currently onboarding the first early implementer states. The 8 states shown in blue here on the map were chosen as initial news funding partners based on their readiness to conduct statewide wastewater surveillance in about mid-July. And that feels like 10 years ago right now. As wastewater data are not routinely used by the public health community, our goal for the initial funds has been to engage COVID-19 focused epidemiologists and health departments to become familiar with these data and learn how to integrate them into response decisions. So states represented by the red asterisks are those that have chosen to use non-news specific CDC COVID-19 funds for wastewater surveillance activities, and as such are also seen as early news partners. There are a lot of different flavors of partners right now. Currently, we are working with these states to develop formal work plans for their wastewater activities, and we expect routine submission into the system by several states over this current month right now. There are also many other states not shown here that are now actively engaged in wastewater surveillance, who we hope to formally partner with in the very near future. So to share a little bit more about the online resources, the news landing page on the CDC COVID surveillance site provides an overview of wastewater surveillance, the advantages of this approach, and guidance on how to engage with news. So through the landing page, you can also access guidance pages for implementing wastewater surveillance. And because the science is still developing, as we all know, and every wastewater sample will definitely be unique, these documents are not set protocols, but rather a general guidance for implementers around strategies and data quality, which is incredibly important here, that must be evaluated with respect to the needs and capacity of the implementing jurisdiction. So the guidance pages include technical resources on sampling strategies, which I'm not going to go into separate slides on that, how to safely collect, store, and ship samples, data submission to news and trend analyses, interpretation and use of surveillance data, and how to share the data with the public most effectively, which might be one of the most important things here. We also have guidance specifically on the benefits and challenges of targeted wastewater surveillance, with specific considerations for application at schools, correctional facilities, and high density critical infrastructure workplaces, such as like food processing facilities. Finally, we have a guidance document on testing methods for SARS-CoV-2 in wastewater. This guidance covers sample processing, laboratory controls, and biosafety recommendations, among other things. And as I mentioned, we are also coordinating something I call communities of practice as part of news at the CDC. These communities will allow for effective communication and sharing of information between states and localities that are conducting wastewater surveillance. Specifically, we have three separate communities of practice right now. One is hosted by CDC to support health department implementation of wastewater surveillance programs, including a development of sampling strategies for different phases of the epidemic and for various public health data needs, as well as data coordination and use. Another community of practice is hosted through a partnership with the Water Environment Federation for wastewater utilities, who have always really been public health partners, but are new partners in this disease surveillance. So this community is providing training and information for utilities to understand this new system and discuss why the utilities would want to participate, as well as discussing any concerns they may have with participation, like worker safety, data sharing, et cetera. Finally, we have a community specifically for public health laboratories conducting wastewater surveillance that is hosted by APHL. This community shares and discusses methods, issues associated with data comparability across labs, materials and performance of the various performance of the various controls, and biosafety. It also includes a coordinated forum for industry to share the incredible number of new technologies being developed to support wastewater testing for SARS-CoV-2, and that is a rapidly expanding thing. So finally, I want to conclude by giving you all an idea of how we combine testing data at the CDC with data from utilities and other surveillance indicators in a dashboard for rapid public health use. So the figure you see in the figure on the left side was published by our utility collaborators in Virginia, and it's a really great example of how we are currently spatially representing and presenting the data through the Decipher dashboard. So each square is a map of the wastewater results for a specific date covering 9 separate wastewater treatment plants. And the colors are a heat map representing the viral load at that plant. So with increasing load going from blue to red, and as you can see, it's also changing in load over time. So the figures on the right, those are a presentation of our trend analyses of wastewater data alongside the clinical data. The data shown here are from 5 wastewater treatment plants across the state labeled A through E. The gray bars and line represent the case data based on the report date, and the black dots and line are the twice weekly wastewater data that have been overlaid. The trend results are shown in the bar at the bottom of the graph, and this is for interpretation purposes with an assignment of either growth, decline, or plateau, as well as if that trend is sustained over time. So I want to end this by saying that we see this as a long-term investment in a very new type of surveillance here in the United States for our public health toolbox. So we're building the national wastewater surveillance system to be a flexible platform that can incorporate new targets and provide data on multiple health targets at the same time. The system can even be adapted to incorporate genetic data that is rapidly compared to clinical surveillance to track pathogen origin and evolution. Some of the potential additional targets we foresee include things like antibiotic resistance genes, bacteria and enteric, or as they're known, foodborne infections, and there's a growing interest in applications to surveillance for hospital-associated pathogens and potentially influenza virus as we enter flu season. So I want to say thank you very much for your time and for allowing me to speak today. And shown here is the news email box if you'd like to discuss these topics further or ask questions. So thank you very much.
Thank you, Jeffrey. And I just wanted to, again, just to have the kind of national leadership on this particular topic coming from the CDC. So thank you very much for that. Um, I'm going to take a lead from the way you set it up there, and those two groups that we're talking about, kind of utilities and health departments. And so we have the opportunity now to essentially kind of explore that a bit more too. So I'm going to turn it over to Steve Rode to talk about MWRA and kind of that perspective from the utility side too. So thank you, Steve, for joining us.
Thank you. So my name's Steve Rohde. I'm the Director of Laboratory Services, and just give me a second to share my screen. Share and let's get rid of that. Slideshow. All right, how's that look?
That's great.
Great. So we are doing a pilot study. We started testing samples or sending samples to be tested way back in March. And so we have the longest timeline of wastewater data, I think, of anybody in the country. We were working both with sort of concurrently with BioBot and with Eric Alm's research group at MIT, which is where the BioBot co-founders started out anyway. And there's a lot of people doing this now. Internationally, I list a few. I just read there was an article apparently last week in the New York Times that said there's over 140 universities in the United States that are doing wastewater testing now. And we have provided research samples not only to BioBot, but also to combined Stanford University of Michigan study, Northeastern, a startup company called Active Signal, and UMass Amherst, and all of them looking at different aspects of the wastewater epidemiology for COVID. We were listed as a co-author on a published paper. Actually, no, we were not listed as a co-author on the paper that's been published, but we are listed as a co-author on a preprint that was posted by Eric Alm's group, and have asked to work with them on a second paper as well. Jeffrey talked about this a little bit. It's really difficult to figure out, to make that jump from how much RNA is in the wastewater to how many people are actually infected in the service area. And this is an example of some stool sample analyses. And you notice that the axis on the left is log scale. And so we're talking about the difference between, on the red, and in the red ones, from 100 copies per gram to 100 million copies per gram. And so obviously that makes it very difficult to take what we're seeing in the wastewater and convert it to an actual number of people that are infected. And then additionally, the wastewater data is affected by other variables. We see a lot of day-to-day variability in the quality of our wastewater that's coming into the plant anyway. For us, because we're a combined sewer system, when it rains, things get diluted by a lot of water, but that doesn't necessarily mean the signal goes down. Sometimes the signal actually goes up when it rains, and we're still trying to understand that. So we started in March with a preliminary request for samples. We had previously been in contact with BioBot in 2017 when they were working on an opioid study, and they came to us looking for a consolidated sampling point where they could get to the entire city of Cambridge, Massachusetts. We weren't able to accommodate that. We don't actually have a single connection to the city of Cambridge, or most of our cities that we serve. And then they came back to us in March and said, "Hey, we think we might be able to detect this virus in the wastewater. Can you give us some samples?" And I came back a couple of days later and was like, "Yes, it worked. We got it. Can we get more samples?" I said, yeah, I've got samples archived on the shelves for 3 months. And so we did actually end up analyzing samples all the way back to January. We saw the first detect from March 2nd on one side of our system and March 9th on another side of our system. So we knew there were cases from January 26th in Boston, but that case apparently never showed up in any of the samples that we submitted for them to test. Then we, did daily samples for the month of March and continued on from there at varying frequencies depending on who was actually doing the testing, whether it was BioBot or Eric Holmes' group, and how things were going. We end up doing daily samples through the beginning of reopening to look at the how the reopening affected that, and that's one of the papers that they're working on, that they've asked us to help them with. They also did some concurrent testing in neighborhoods in Boston, water and sewer in different neighborhoods, and those results are actually in the preprint that's online from them. So currently we're doing an ongoing pilot program with them. So we sample 3 times per week or more from Deer Island at 2 locations. So we increased it to daily if it looks like things are going up. And unfortunately, we've been on daily sampling since about the last week in October at this point. The pilot program is scheduled to run through January 2021, but we are working on a procurement to extend that into and possibly throughout all of 2021. The results are shared with the State Command Center as soon as we receive them. The link on the slide is where you can see the data, which I will show you in a second. And I already mentioned the procurement in the fall that we are working on to extend this into next year. And so here's the data. Color coded, the green is the northern part of our system. All of the samples are collected at Deer Island, which is the black dot. The orange is the southern part of the system that we serve. So we have 2 separate influents that come into Deer Island from the north and the south. And then on the left is the actual timeline of data with error bars shown. And so you can see the trend there that really peaked in April and then has started to increase in mid-October and is unfortunately still trending upwards at this point. That's all I have. So the solid lines are the 7-day average results, and then the individual data points with the error bars are the actual individual sample data. So that's all I have. And I don't know if there's questions, or we can move on to the next speaker. I'll be around if there's questions later on.
Thank you, Steve. Thank you for that too. And I know a lot of us have been looking at this data and taking information from it to think about our own actions. Well, we definitely have a question, and we'll come back to that too. But just to make sure we get a chance for each of our presenters, we'll kind of move through that and come back to the question. So thank you again for that presentation. Going back to that framework that Jeffrey had used, so we've talked a little bit about what's happening kind of at the utility, at that kind of larger scale across a number of different cities and towns. Now, I want to move now to kind of look at essentially how some cities and towns are thinking about and using that data and why they've approached it that way and how they're using that work too. So I'm going to turn it first to Sam Lipson from the City of Cambridge Health Department.
Hello, glad to be here. Really enjoyed the presentation so far. Yeah, we were just at the very beginning of this. It took a while to get all the contracts set up and some of the field logistics. We're, as was already, I think Steve already indicated, we're part of an integrated system in Cambridge. This is right over the river from Boston. We have a lot of interest, partly because of our historic relationship with BioBot, the early work they did when they were at MIT, and the work with Eric Alm at the Alm Lab. We were sort of aware of the technology and its potential use for a while going back. We've had discussions with them about tracking opiates before the pandemic. And we've had conversations throughout the summer with them while we were observing the MWRA data. There was a lot of interest, which finally did result in a contract, which has begun now. We're on week 4 of our data being collected. As I said, we've had some issues with trying to find specific locations that will capture as much of the city as possible without also capturing too much of other communities, so that we have some idea of what the Cambridge signal looks like. So as a result, we have all of Belmont pretty much, and all of Cambridge. And we're in 4 different catchment areas. I was going to try to share the map. It's interesting, but doesn't really add that much to the discussion. I think you guys have all seen catchment area maps. We've had to go through MWRA to get permits, because if you're going to try to collect samples that represent large catchment areas in this area, it's very likely MWRA actually controls those locations. So you have to go through them. We currently have one sample per week. So, you know, the data is really rough and jumping quite a bit. We've had to try to appease the sense of urgency from our city council to get everything online, balancing it against the need to get some idea of whether the data is ready for public consumption, and what we will do to explain and frame the sort of variability. We have even higher variability than MWRA has. As you can imagine, the smaller the collected source, the more you're going to get variability. Some of it is lab, some of it is field variability and conditions that we don't entirely understand, as Steve pointed out. So I'd say the biggest challenge for us, now that we kind of have everything in place, is how long to observe data before we draw any conclusions from it. And I think these are the same questions for a lot of communities and regions. What would we consider action thresholds, and would we in fact use it for that purpose? I've been trying to share when asked either by media, which is the local stories, or through our city council and our mayor, what the immediate value or application of this data is. And I've tried to emphasize that it's an emerging technology. We don't even know our own baseline. We have to understand the data a lot better and maybe have more of it. But more importantly, that it's probably better to think about it as an early signal that may be imprecise, but if is appears in a really dramatic fashion, may buy 5, 10, 15 days of time to plan either direct deployment to certain neighborhoods where we're seeing real spikes, or change our messaging, or change the frequency and availability of testing. The question around what to do with that time is really not a technical question. It's a public health response question. But I feel like framing the data for public, to explain it to the public in a reasonable way, and developing a plan to take advantage of the time that we may have bought by being able to get an early signal, are sort of the things we're thinking about at this point. So I think I'll stop there and see if there are any questions.
Thanks, Sam. I'm sure there will, particularly to that kind of local expression and what that work looks like too. I'm going to bring it over to Karen again to hear a kind of another perspective from kind of the public health department side, local public health department side, and just to take a moment to recognize Sam and Carol and all the other local public health folks online. You all just deserve a lot of appreciation and a lot of respect, and just to extend out our thanks for all the work that you're doing too. So I'm going to turn it over to Karen to talk a little about the work in Gloucester, and then we'll kind of probably have one more brief presentation and then come back to questions. So turn it over to you, Karen.
Sure. I'll keep it brief, because a lot of my points have already been said by all these great speakers we've had this morning. So I'm Karen Carroll. I'm the public health director here in the city of Gloucester. And we got the idea, I had attended a national conference a year or two ago that talked about wastewater tracing, that someone's already mentioned today too. And so when COVID started coming down the pipes, and we were in the spring looking at not having enough testing and not having a fast enough response time for the testing, and yet we were trying to plan at a community level for a pandemic, we just felt that a wider surveillance tool would be useful. And then there was an article or something that came across my desk, or maybe the newspaper, about BioBot, which someone mentioned, involved in this area, doing this kind of testing for certain communities. So we reached out to them immediately and said that we were interested in having conversations with them about the limitations as well as what it could offer us. And our board felt, the Board of Health, as well as the state, they supported it with the CARES Act usage. Felt that there was enough sort of community-wide predictive information out of it that would help guide us in this world of COVID, where things were exploding so quickly, and we did not know what was going next, and we did not know what other tools we would have, and how good those tools would be. We also really liked the idea, this is the only sort of whole population surveillance we have for this one. So we liked the idea of not just looking at the positive cases as they came through, because that's really such a small portion and it's kind of after the fact. So that is the why we did it, and we used CARES Act funding. I think I mentioned that we started in August, and we started tracking our own baseline. And when I show you the graph in a minute, I think you'll see how we were able to establish roughly what we called a baseline, and then some interesting things. So I think maybe if we just go to the graph, I think a lot of our story can be told with this graph. So I'll do that, and then if there's questions that I didn't address. Actually, the one thing I do want to say, our previous speaker talked about what you can conclude, what people want to do with this information. So from day one, we stressed that this is just one more piece of information. Like we stressed the red map on Wednesday that came out and made you yellow or red, that was one indicator. It was a good indicator, it's incidence, it's important, but it was one indicator, and we were never going to make all our decisions based on any one indicator, whether it would be opening schools, visiting, restricting tourism, whatever our decisions that we felt were in front of us. So I feel like we've kind of drilled it into people that it's just one more indicator, and it's not perfect, but it can help create a little bit more of the story. So when we present this data, it's never in isolation. It's part of a press release with wider data points of activity of what's going on in the community and statewide. And we also use it in conjunction with the DESI indicators, the 6 indicators that the state uses on its daily dashboard. So we have this sort of one pager that whenever I present to boards of health, school committee, any other key stakeholders in the community, trying to get a full picture of what's happening with COVID in Gloucester, we again make sure it's part of that whole page of 10 different or so factors. So I do want to stress that, because it is not something that you can just use on your own. Also in Gloucester, one more point, about 20% or maybe 15% of our population is not on the town wastewater system, the septic system, sewer system. And our data also includes the little town of Essex, which is next door to us. So again, we had to really stress to people, you're not going to see a direct correlation, a one-to-one. It's not comparing apples and apples, if you like. So I'm just going to talk about these top 2 graphs because I think they're really interesting. And I want to thank the Public Health Corps in Boston through the governor's office that has helped us do some of this graphing. And basically, we just asked them to put our case count over time against our virus count over time. Now, I'm not going to get into the technicalities of normalized virus versus raw virus. Those are all interesting, but I think we've got plenty of experts on the line that can talk about that. But basically, it just gave us an opportunity over time to compare these things to each other to see how it was trending. So as you can see in the early months through August, into September, the light blue line, the aqua line, is our normalized virus line. So we bounced right around the level of detection for several weeks into early October. And our case count stayed pretty low as well. And again, some really useful ways in which this information helped us in the summer was with tourism. Gloucester has a huge influx of people coming into its community from all over the state, all over the country. And so, our public beaches, our parks, our hotels, restaurants, they're all feeding into this system. So the fact that we didn't see spikes as we had thousands of tourists at our beach every day was really reassuring when, we worried about that. Do we want these people? Are they bringing virus? What's happening? So again, it just helped us to feel like we were okay where we were, and we had established a kind of baseline, again, right around the level of detection, which is suggested by Biopod of 3,600 copies of virus is the level in which you can start roughly to detect it in a community. So sorry, I think these lines got mixed up. No, that's correct. And you can see how when the normalized virus, there was a small spike in October. And that was a cluster we had. It was a small cluster that was related to a specific social cultural event. And although it was a fast increase in cases, and on the next map, you'll see it brought our incidence shooting up. The BioBot testing was not an early indicator too much for that. So that is one of our puzzling points, is why we didn't see a spike in the virus level before we saw the climb in the darker blue line, the case count. And we still don't really know why. I can't really answer that. My thinking after we've gone through things is that we were looking at an isolated cluster, not wider community transmission. So, and what you'll see, the case count did come back down very quickly. Within about 2 weeks, we had widespread community testing brought into Gloucester, and that small outbreak of 75 people quickly came down over the next couple of weeks to a point in which you can see it on October 31st. It was kind of back to a very low level of cases. And then around that same time, our cases were coming down, you see the virus going back up. And that, I think, was the early indicator, and it continues to go up to over 300 parts of virus at the moment per liter. So as are our case counts. So I think that, there's kind of the story in there that we were able to learn a little bit more after the fact. But again, if you go to the next graph where we look at our average daily incidence, which is the dark blue line, again, graphed against the same thing, the virus level, you see this sort of steady, and then a spike in our incidence back in mid-October, which was again directly related to a very fast and short-lived outbreak. And then our incidence level came back down. And now as our case numbers are going up, that incidence rate is going up as well as our virus level. So to me, the story here is that it's been a pretty accurate reflection of what is happening in our community and the subtleties between a contained cluster and a community-wide transmission. I think you can start to see there. Now, I know you can't definitively draw those conclusions. But for us, it's been useful more. I think we've used it more as a reassurance that we're seeing what we think we see, and it seems to be true, and it's being reinforced by the virus level in the wastewater. And in terms of actions and how we use the data, again, I think I've highlighted some of the ways. It was particularly important early fall when we were trying to open our schools. And it was very, very reassuring to the school committee, the school community, and parents to continually see that the wastewater levels were low as well. So it was a very helpful tool in moving that along and providing that reassurance to people. And the other way that we use it is in our media and our press releases. So we report this data, I think, as I said, on our city website every week, and we do it in conjunction with other indicators as well. I think those are kind of the main points I wanted to make. And, I think a lot of the other points have been made by the other speakers. So if people have questions, I'm happy to answer it. We found the onboarding and the whole logistical thing very simple. We worked with our DPW who runs our wastewater plant. We told them what they needed, BioBot and those people connected. And really, we get a report every week. It's an automatic pump draw for over a 24-hour period, which I think people know it's proportional to activity. So they draw the most sample in the morning when people are getting ready for work. So it's proportional to community waste activity, if you like. And we get the report every week. It comes in, there's only one indicator, and that's level of virus. They compare you to other parts of the country. They compare you to your week before, but there's not a lot to it. And we found that process to be quite simple.
Thank you, Karen.
Yeah.
Those are really, really helpful too. Sorry, I think my audio might be. Anyway, just want to pause there because we had two quick questions just to see if people have thoughts. The first one was to you, Steve. In terms of updating data on NWRA's website for weekly data, is there a kind of a regular or kind of iterative nature in which that data is posted, weekly, daily?
Sorry. Yeah, so, right now, like I said, we're sampling daily. There was a bit of a delay getting results over the Thanksgiving weekend. And then there was at least one sample that we received on Monday that looked kind of different, and we asked them to reconfirm that, and we held off posting that data until now. In fact, it's probably up now. Actually, the graph that I showed you included the updated data. Right now we've been getting results pretty much on a 2 working day schedule from BioBot. We don't deliver the weekend samples to them on the weekend. We deliver them on Monday, and then those results are reviewed by staff in the command center before we post them on the web. So.
Great, thank you for that.
Yeah.
I was going to turn another question to Jeffrey and to Karen. I think someone had indicated whether or not something like this could work when you have people who are on septic, and how you might be thinking about that too. So I wasn't sure from the CDC perspective, anything you might have around that, and Karen from Gloucester, how you've been thinking about that 25% or folks that might not be on.
Yeah, that's a challenge. I think the bigger picture, the hope here, and thank you, Karen, for explaining as far as what kind of percentages of individuals are approximately on septic systems. Like I was saying earlier, the system we're envisioning or we're looking at right now, and people are trying to implement, is mainly for community-wide spread, community-wide sampling. And so the goal, or really the hope, is that even though there are individuals on septic systems, those people who are not are going to represent, the full spectrum of what we're seeing. That's a challenge right now. We're still talking about what that means, especially we're not incredibly concerned about it for metropolitan areas, but mostly, like we're seeing, for coastal and rural areas, if we're really not picking up a much larger percentage. It is still concerning. 15, 20, 25% of individuals are not on a municipal wastewater system, but we think it can definitely be made up looking at the whole community in the sewer shed. But that is definitely a challenge, and we continually have discussions about what that means to us and how to interpret the data.
Thank you.
I can just say in Gloucester, we were worried about this too, how much it might be skewing things. So for a while, we had our nurse contact tracing team providing the street address to us, and then our septic people would look at it and say, well, that's a street that is or isn't on. And we found there were not many people, we didn't have many cases that were not on the public system. So we didn't need to worry about it with most of our data. But again, we haven't been able to continue to do that. As the caseload goes up, we don't have staff to do that. So now at this point, we don't really know, but we did give some thought to that earlier. And I think there's probably ways you could program, at least to see if you have people that are, falling into that category.
There are some, this is Steve Rohde, there's some logistical issues living in a house where I have a septic system with regards to sampling septic systems. The virus does, or the RNA does tend to preferentially stick to the sludge. And so that sludge in a septic system typically just accumulates and naturally breaks down. And so it's difficult to say, to be able to sample that and say this is a new sample or you could potentially sample the liquid portion that's going over the baffle and out to the leaching field. But there's also, you run into, one of the benefits of the wastewater-based epidemiology is you get around some of the privacy issues with sampling individuals. If you start going back to septic systems, you're back into data that potentially would be HIPAA non-compliant. So.
Thanks, Steve. I was gonna go Sam.
Oh, yeah, no, larger cities, it's unusual to have septic. We don't even allow it. It's not, there's a local code that prohibits it, so it's not really an issue. I wondered if I could bring up a separate question. This is sort of about, BioBot's been doing this work to try to establish their methods for a while, so that we really benefit from a lot of their insight. But one of the things that seems really important is the extent to which we're able to correct in any given sample for the relative contributions. And some of the obviously interfering factors are things like rainwater, but also how many individuals are contributing to a sample. They have some metrics or markers they use to indicate how many people contributed to a sample, but it feels like this area of normalization of data is really going to be important. And I wondered if anybody here on the panel had any thoughts on where we might be going in that direction.
Hi, this is Jeff again from the CDC. So this is definitely a big issue. What does normalization look like? And what we're seeing just from our experiences in speaking with lots of different states, municipalities that are doing testing, the majority of them have some form of normalization to try to get at what the contribution is. And so this is the difficulty of matching up number of people with how much, what your signal is, and that sort of thing. This really goes down a really deep rabbit hole. The types of normalization we're seeing vary pretty widely. I mean, everything from the genetic side to how much flow, and they're all, I would say this, assuming that whoever's doing the testing and how that testing works, assuming that it's all done the same way every time that a sample is taken and then collected and then tested, as long as you can standardize that and not change methods for how you're doing normalization for a particular sample, that should ease out a lot of the noise. And where we like to come at this is to understand trends that should allow you to understand the trends in the wastewater sampling data, in the wastewater testing data. It may not be a very, depending on your type of normalization, may not be a great way to say, well, this is our level of prevalence in the community based off of this. That's a very difficult metric. But at the very least, if you have normalization that is standardized and done each time the same way, you can at least start to look at and compare trends and understand if you have things going up and down. I know that's not a perfect answer, but this is definitely an emerging part of the question, part of the surveillance system.
Great.
Thanks, Jeffrey. Thanks, Sam. I'm going to begin to wrap us just so we can make sure that we get out of here at 11:32. So really, again, to say thank you to each of our presenters. Thank you for both kind of sharing your expertise and your experience. I think it's been very helpful to kind of learn again how this is emerging, how we're doing it in Massachusetts, how we're doing it at the city and town level too. For those who've posed questions that we haven't gotten to, we'll do our best to follow up on those particular questions. I would highlight too, so there's some tremendous resources that are on the call here too, I think, who either they themselves or their organizations are very accessible. So please feel free to reach out or reach out to MAPC to help with that. MAPC is also involved with a wastewater monitoring project. Are fortunate enough to be involved with one in the city of Chelsea as well too. And so working with the Center for Complex Intervention, BioBot, but I think to Karen and Sam's earlier point, kind of how important it is working with the Department of Public Works staff and kind of the local staff to help those things really happen too. So feel free to kind of reach out to us as a resource as well too. So I think I might end on kind of Karen's point that essentially like the more data I think we have in the round to really kind of inform our decisions kind of helps us kind of really think about how we're going to respond. And to, I think, a question in the context as well, this is a tool that not only kind of speaks to this moment in time, but it's something that has utility as we go forward, whether that means as potential vaccine rolls out, where we might see potential spikes. How do we kind of continue to monitor this, imagining that it won't go away? What are some of those other things that Jeffrey highlighted that we can really look at within the wastewater to provide more rich local data around kind of the surveillance and monitoring piece? So it ends up being a really important piece. There's a story that I don't know completely well, but I think is really interesting around kind of how wastewater played a role with polio eradication. And so just that idea as we think about what we can go forward and really kind of reduce the number of risks that our residents experience from kind of a public health perspective too. So I just want to say now again, thank you everybody for your time. Thank you for spending it with us. Thank you again to your speakers. We really, really appreciate it. And please look for follow-up information for us from this session. Thank you all and have a wonderful day.
Thank you.